anterior pudendal plane, and seeing everything symmetrically is not easy. So what I'm going to do, I'm going to come here, relax. Thank you so much. So, again, it's the same principle. The reason why I insist on doing a normal case is because right now you will not be able to do what I just did, yes? And I'm afraid you can already see the abnormality. And we know that this is not a whole person carefully because there's midline, yes? But whether there's a thin membrane is questionable because it must be very, very thin in between the two ventricles. If not, then it could be completely disrupted. Yes, and then the cortex is very thin. And I know the posterior fossa is also pretty much squashed posteriorly because I quickly did well, we will see when we will proceed with the transabdominal scan after the transvaginal scan. But in general, I always do if it's cephalic, I must do a transvaginal scan because, see this, 1 second, let me try and get my music back on. Don't worry. Let's see which song this baby likes. I will always go with the Baby Shark first. And so, can you see? This is you can appreciate the cortex anteriorly, and then and actually I'm already getting to the midline, which is over here. May I just say, don't panic when you see something like this. Follow the normal process whereby you find massage the plane, and this is the moment it will be helpful to do the periclothoracic because you might not be so sure where the corpus callosum is whether it's present or whether it's just extremely thin. Yes, and then if I move the transducer to the anterior compartment, I will change off this, and then I will basically put the video, please, okay, and then you go to the anterior portion. And you may say that, is it useful to do this transvaginally? Yes, because I appreciate the whole brain on both bilaterally. We don't just look at one side, yes? This is the advantage of the transvaginal approach, and then you can look into the brain through the anterior fontanelle. And you can see the optic tract, yes? Optic tract. So go into anteriorly and go into the posteriorly. And then see whether we can appreciate this is basically cerebellum in the back. It's very squashed. And I'm afraid I have limitations in terms of the movements of my transducer because I don't have full lithotomy here, but you can appreciate everything, yes? So now let's go back to the midpoint and see sagittal plane. So to talk and do this, and then to control the button color. Let's see. So this is the moment I think always 3D MR imaging is going to be helpful. We need to work out the cause of this case, and then I think I'm afraid because we are trying out a brand new machine, we haven't had the time to optimize the Dopplers. Dopplers have to be optimized, otherwise it's not going to be helpful. This is one lesson for me, and for all of us. Another thing is that you need to also look out for any obstructive picture. The rest of the scan has to be done. We need to know whether it's a boy or a girl, but we know that can happen in girls too, although it is X-linked. So usually you go and look at the phone, make sure you look out for any phone, you look at the gender, you look for other features, but in the case of hydrocephalus, the number one differential diagnosis must be element count. And we will have offered amniocentesis, we have done genetic testing. And then going back here, I think because I don't have the it's very, very significant hydrocephalus, yes? And I'm not entirely midline. So let me see if I can make it more midline. So I'm pressing the abdomen on the other side. See? So trying to get this baby to, more midline, yes? And rotate like that. Just, so I'm kind of demonstrating the techniques more than anything. I think, to diagnose hydrocephalus, all you can do. But then how you improve the images. And this is really the moment when you are in doubt whether the corpus callosum is there, or whether it's completely absent, or whether it's just been squashed because it's a really high pressure system. And then the pericallosal artery would help. And I think we can try one more time, but let me see if I can get a better view. So proper lithotomy would be very helpful because at the moment I don't have room here. I'm restricted by the legs. The legs got to be a bit more, better position. My probe cannot go beyond, my transducer cannot go beyond. So, what we can do, I'm happy to proceed with a transabdominal scan just to see what else I can see transabdominally. Any questions in relation to the transvaginal scan?
Dari peserta ada pertanyaan kira-kira? Ditunggu 1 jam lagi. Ada pertanyaan kira-kira mau dilihat? Ini kok kelihatannya air semua yang kelihatan ya? Ya, hydrocephalus kali berat. Leona, can you appreciate the thalamus? Is there any way we can see the thalamus?
Sorry?
Is there any way that we can see the thalamus?
I think we saw is here. Sorry, because it's very squashed, yes? Let's reduce the gain. And then, it's already looking down. Sorry. Let me try and look up again, get the baby to look up again. Because this baby's looking down, yes? And I saw earlier. Actually, I just managed to get the pericallosal artery appearing. Not sure whether you saw it just now. So this baby's head is looking down, and then I don't have an extra pair of hands to do all the buttons. So training your buttonologist is so important here. I'm trying to entice this baby to look up. So I'm aiming more to the anterior portion, yes? You can see I'm going towards the anterior portion now. And then they're there. I just more or less around here. I just don't have the hands. Oh, yeah. Because so there you go. I think you can appreciate, yes. You can appreciate the anatomy, the midbrain, yes. Am I right?
Yeah, very clear.
I mean, you can see. So the key is what? You must go more towards anteriorly. So now I'm in the midline, yes. I will bring the transducer to the anterior frontaler. And you can see this is anterior frontaler because you can see the indentation. I rotate on this. And then I'm very anterior. You can see the eyeball and you sweep backwards. And you can appreciate. I'm very systematic here, you can see. Yes, no doubt you can appreciate the anatomy. Symmetrical, I'm not seeing any obvious lesions that could be causing this hydrocephalus. May I say, I don't know whether it's because it's too squashed. Normally, we will question the fourth ventricle, the third ventricle, and the aqueduct of Sylvius. So this is actually, we will be very much needing an MRI. I don't think it's because we can't do it. It's just that the definition in soft tissues, we have limitation, especially at the gestation. Maneuvers are very limited, but I'm not seeing anything drastic suggesting aqueduct Sylvius obstruction, but it could be because this is just so dilated that I can't comment on this, because the whole back, this is completely dilated, right? So we will appreciate MR, and then we also do a transabdominal scan and look at the rest of the baby, look at the thumb, etc. Yeah. Just now I was able to go to the anterior portion, and then I was able to demonstrate the peripheral artery. I don't know, we didn't manage to save it, okay, we didn't save it, did we? Because it's not coming up. So just remember, when you want to show the peripheral artery, you need to go to the right place. Okay, just looking down, there you go. And color, more or less. Let me just try to, can you see? You can just follow, yes. So because this baby is moving, move the box up. Box up. This is like a real challenge. But you can see there too. Because a whole vessel will be surrounding, yes? So this is, yes, you can appreciate this. Yes, this is the whole, I'm sorry, I'm trying to give instructions. Yeah? So you must, so this, Audrey, this is the moment you must do this, not for the normal case. Because this is when you have any doubt, when you see the peripheral artery, then you suspect that you will be able to see the focus. Yeah. Now, beautiful, yes? Okay. Any question?
Yeah, regarding for your best experience, whether we can categorize this case as a poor outcome for afterbirth? Is it beneficial for doing the 50 sum maybe for informing the patient?
Can someone help me? And I can't hear. I'm sorry, Andrew. It's just the acoustic here doesn't allow me. What's the question? Maybe shut. This you must talk to the neurosurgeon, and obviously you just need underlying diagnosis, whether it's an obstructive picture, whether it's a constructive picture. We need to know whether there's infection. So don't just jump in and say we need to do a VP shot. The underlying cause of the hydrocephalus is extremely important. Obstructive or destructive. And then obstructive, you can relieve. Destructive, relieving is not going to save, it's not going to alter the outcome. But we know the VP shot. Of course, the biggest concern will be infection that comes with the shunting, and that will also then worsen the prognosis of this baby. So it is a multidisciplinary approach. You must have genetics, you must have the infection ruled out, you must do an MR, and then afterwards, after birth, then you need to refer to your surgeon. And then if it's an obstructive picture, you may consider a VP shot. If it's not entirely obstructive, if it's destructive, relieving this is not going to help the brain regenerate, yes?
Yeah,
Thank you.
very true. How about the cortex measurement? Is it also necessary to do cortex measurement? The lateral cortex, I mean the size of the cortex that is measured by the ventricle, it's not necessary.
No. Basically, I think the severity of the ventriculomegaly right now is enough for us to to show that at least 50% neurodevelopmental delay. And then underlying cause is really important here. The cortex, the thinnest, if we know is destructive or obstructive, then maybe we will know. The thin cortex is as a result of the ventriculomegaly. If the ventriculomegaly is caused by obstructive picture, then it may be just pressure effect. But if it's destructive, then actually it's damage to the brain tissues, and then there's a different prognosis. Okay, I'm going to finish here.
You want to transfer to the abdominal?
I will try and have a look. Abdominal. Yes. Genetics.